told that they've got wax and just told to use some, I think it was sodium bicarbonate earwax drops. Unfortunately, their pain, if anything, got worse, and that's possibly because this keratin, it's not earwax the patient's got, it's keratin absorbed the drops, expanded and swelled, created more of a blockage. And the patient booked in with us, I think they called the clinic a couple of weeks ago, but we're really busy at the moment, so we couldn't see them for a week or a week and a half afterwards. And that very same day, the patient was in that much pain that they had no choice but to go to A&E. And when they went to accident emergency at the hospital, they were advised that the ear is severely infected, and they're actually given some antibiotics, and they were told not to have the procedure done until after. Now, I would kind of query that advice, because quite often if you're getting antibiotic drops, you'll rather clear the ear out of all the debris so the drops can actually make a difference in the ear. They can be absorbed by the canal wall, they can make contact with it. In any case, so the patient took the advice and came a couple of days ago. They said that their pain had severely improved, but they still was not hearing well. There still was a bit of pain. And so straight away I looked in, I diagnosed the patient with keratosis obturans. So keratosis obturans is different to impacted earwax. Everyone's ear canals are lined with skin, and so is the outermost layer of the eardrum, so the most lateral layer that's facing us, and the eardrum's made up of 3 layers. As that skin dies and sheds in the ear has evolved over millennia so that this skin moves sideways out of the ear in almost like a conveyor belt motion. So in essence, the ear is self-cleansing, the skin dies and it comes out the ear. If it didn't, then everyone's ears would be full of dead skin. So this dead skin would die, it would collect in the ear, and everyone's ears would be blocked. So the skin has evolved so it can move sideways. Now, in a small percentage of people, this skin doesn't, and it forms a matrix, a plug of skin, typically medially on the bony part of the ear canal, deeper in the ear canal, and it just collects. And this dead skin has almost got a rubber consistency, it's very springy. And this dead skin, layer after layer after layer, it forms a plug, and this plug then expands and widens. It can be excruciatingly painful. It can start causing erosions of the ear canal, widenings of the ear canal. In the worst case scenario, it can start chewing up flesh, and it can also reach the cartilaginous portion. And it's a very difficult thing to remove. Dead skin can be very strongly adhered. It sticks to the ear canal. It can be very, very tough to peel off. And so as I was talking, you just saw me removing skin, and you can see there's a little granulation tissue here. And on the opposite side, on the left-hand side, so that when I say granulation tissue, this is that little red pimple. That's what we call granulation tissue. And that's located at the osteocartilaginous juncture. So where the cartilage of the ear canal, so the outer third, meets the bony part of the ear canal, the inner 2/3. And keratosis obturans have different grade systems. This one I would grade as a grade 3. So you get a grade 1, which is just mild earache, no discernible expansion of the ear canal. Grade 2 is a bit more pain, and there is some visible mild expansion of the ear canal due to the plug. So this plug, think about like a rubber ball getting bigger and bigger in your ear. It will start widening the ear canal and causing expansion of the ear canal. Grade 3 is when you've got really severe pain, which this patient did have, and also quite a noticeable expansion. You can see just about a centimetre further out, just here to the right with that granulation tissue, there is quite a wide expansion of the ear canal, and we have some granulation tissue, which is that pimple. So what's granulation tissue? Granulation tissue is a formation of new connective tissue during the healing process. So when your body's gone through some trauma, during the healing process, we get formation of granulation tissue, and that granulation tissue develops its own capillaries, blood supply, giving it the red, rough surface texture. And typically as well with grade 3, which this patient didn't have, is when you've got this dead skin as well, this dead skin plugs, the matrix itself, that itself can have its own blood supply and blood vessels, capillaries forming. And when you start removing these layers of skin, the matrix of skin, you burst these blood blood capillaries when you get some kind of bleeding. So it's not that the bleeding is not caused by the audiologist scraping the ear canal or cutting the ear canal. It's just by the rupturing of these capillaries that are formed in the matrix of these layers of dead skin. So the idea here now is just to mop up as much as we can. The patient is aware of what the condition is now. They're going to have to, they are aware that they're going to have to get their ears cleaned regularly now, because when you've got an expansion of the ear canal like this, it's very, very likely that we're going to get skin formation again. So as the skin migrates out of the ear, it's going to get trapped in this expansion, this widening, this erosion of the bony part of the ear canal. And then obviously that can lead to a chronic condition of keratosis obturans. So the patient's fully aware now that it's been diagnosed. Have to keep on top of it. Now, what's interesting as well with this case, so I'll just show the granulation tissue on the left as well, so you can see on the right, and you may not see it there, but there was some granulation tissue just to the left of screen, hopefully. I'm not sure if I'm going to zoom in on it, but you'll see it right opposite that pimple appearance on the right-hand side of the canal. There's some granulation tissue on the opposite end of the ear canal, and that's on the osteocartilaginous juncture. That's a trademark of a grade 3 keratosis obturans. Now, what's also interesting about this case is we're going to do the left ear in a moment. And so the patient's got keratosis obturans in this ear. In the left ear, he's got tympanosclerosis. You'll see that. So there's tympanosclerosis is a buildup of scar tissue on the eardrum, normally on the middle membrane, the fibrous the connective tissue membrane. So the eardrum, as I said, has got 3 membranes. The outermost membrane, the lateral membrane, which is facing us, is the same skin that lines the outer ear canal. So the squamous, stratified, keratinous, epithelial skin. The innermost membrane, so the medial membrane, is the mucosa. So the mucosa lines the middle ear. It's kind of similar to the skin that we have in our nose, nasal passages. It can be quite moist, and it can secrete fluid and other secretions. And then the middle layer is a fibrous connective tissue layer, and that's what gives the eardrum its strength, and that's where the muscles are. And tympanosclerosis is a calcification, so it's a build-up of calcium deposits, again in response to trauma, and it gives you a very white appearance, the scar tissue, and we call that tympanosclerosis. So that sometimes can stiffen the eardrum, so when the sound hits the eardrum, because the eardrum's stiffened, it doesn't absorb the sound waves, and so therefore the eardrum doesn't vibrate as much. Instead, because it's stiff and turgid, the sound hits the eardrum and it bounces back out of the ear, so it rebounds it, which can cause a bit of a hearing loss. And on top of that, because when I did the left ear, there's a noticeable retraction of the eardrum in the attic region. And so I did tympanometry, and they can see on the left, you can see the widening, the expansion of the ear canal. There's the patient's eardrum. We're not there trying to remove every little last speck. By doing that, you're going to cause unnecessary trauma. We've cleaned plenty enough. So this is the patient's left ear. It's a hard, solid piece of wax. So at the top, there's a little opening. So I used the St. Bart's ear hook. I managed to glide it in at the roof of the ear canal before I rotated the hook in and behind the wax, and the tip of the hook also embedded within the ear canal, within the plug of wax, and I then slowly extracted it. So removed the occlusion. This patient's ear canal does incline upwards a bit, you can see there. Now, could that possibly be a bit of an expansion of the ear canal due to previous keratosis obturans? Possibly. So this skin, I'm just going to peel as much as I can off the canal wall, because I don't want the patient to develop keratosis obturans in this ear. We're way off that, but it's more preventative. You'll see the scar tissue on the eardrum and the attic, so the top part of the ear canal. The medical term for that is called the attic, or it's called the pars flaccida. The pars flaccida is a thinner part of the eardrum at the top, and it can get sucked in if you've got